I am Dr. Jason Schmidt from the Vance Thompson Vision location in Sioux Falls, South Dakota, and Alexandria, Minnesota. And welcome to the Dry Eye Dialogue, your one-stop shop for all things dry eye related. I've got two of my esteemed colleagues here, Dr. Nick Risperud out of Fargo and Dr. Lorraine Zimprick out of our Sioux Falls office. So welcome, guys. And well, as we dive into the next kind of section, there's a lot of treatments that are coming out or that we're using today. Lorraine, what are your thoughts on some of the modalities you found to be successful in your practice?
Yeah, great question. Just to circle back, I said that to patients, what you said about high blood pressure and things like that. I said that to patients so many times. And it's so true. It's like you go to, you go to your regular primary care doctor and they say, your blood pressure is high, or, you're overweight and you're borderline with diabetes or something. And one of the first things that they say prior to even starting you on any medication is, there has to be some sort of a lifestyle change, right? There has to be this is the first form of treatment would be, you have to work out more, you have to eat healthy foods and, care about what you're putting into your body and things like that. And so, it's so similar with dry eye. It's, the patient that's borderline diabetes doesn't know that they're they would probably have no symptoms of that. The patient coming into our office for dry eye, coming into our office for who knows, whether it's a LASIK, they want LASIK or a refractive consultation or cataract surgery, or glaucoma or whatever it may be, that we're getting these tests saying, hey, you've got dry eye. And there's things that you can change lifestyle wise. There's, drops or whatever medication there may be, but being aware of that's the same thing with dry eye, is that we're able to detect it almost before you're having any symptoms. And so how I kind of look at dry eye, or how I, in a sense, choose what tool in my toolbox I want to use, is kind of figuring out what is causing the dry eye. Someone mentioned before, or Nick mentioned before, the types of dry eye, whether it's evaporative, if it's coming from our meibomian glands and those aren't working quite right, or aqueous, whether our lacrimal gland isn't producing what it needs to be doing, environmental, or whatever it may be. Understanding why the dry eye is there is going to be most helpful in determining what tool you use. And so, there's one of the first things that people use or reach for is artificial tears. And artificial tears are still a great treatment option. You can buy them over the counter, making sure that they're maybe a type of artificial tears that your doctor recommends. But there's types of artificial tears that can target the lipid layer or the aqueous layer or whatever it may be. So it can target, where the root of the problem. It can target the root of the problem. And so artificial tears are a great option. There's other drops or treatment modalities that we can use in our office, like plugs. Plugs are essentially plugging the drain. And so the tears that you create stay on your eye. And so that's really nice because it's your natural tears that stay on your eye. It's not an artificial tear. And so the more that we can keep natural tears on your eye, the better off that we are. Otherwise, going down, there's medication drops that you can use that treat, just like what Jason had mentioned, this vigorous cycle that keeps going around. It's treating that inflammatory cycle, so that we can stop that pathway and get you feeling better. If it's meibomian gland dysfunction, there's in-office procedures such as intense pulse light or LipiFlow, modalities that in office we can kind of treat those glands and heat them up and pulse at them and increase that specific layer. The list goes on and on of things that we can do as far as in-office treatments. What do you guys reach for first? That's kind of a fun question. I guess it really does depend on what type of dry eye they have. But let's just say you have a patient coming in and they're here for refractive consultation. They don't necessarily know that they have dry eye or care that to be honest, care that they have dry eye because we're the ones telling them, hey, we're starting to see the signs and stuff. Do you guys just go to artificial tears, or do you guys put them through a dry eye workup? Or what do you guys do?
I'll go first because Jason is probably going to sound really, really intelligent because this is, his area and it's not necessarily mine, but I do like treating it. So I'm going to interrupt and go first. For dry, I mean, if patients complain about dry eye, I do, first thing I look at is lids. I mean, the problem is like, statistically, the problem is likely with their eyelids. Okay. Either meibomian gland dysfunction or some blepharitis. Um, blepharitis is so common. And I mean, before we go to bed at night, we all brush our teeth, right? We wake up in the morning, we shower, brush our teeth, right? But like we wash our hair every time we take a shower. I think, people do that. But how often do you like wash your eyes? And it's not like you're going to use soap and scrub your eyes. But how, like, we never would think we wash our hair, we brush our teeth, wash our eyes. We don't think of that. We should, because looking at some eyelashes under the microscope can be pretty nasty. And so the purpose of our eyelashes are to keep stuff out of our eyes. So like, you know, for people out there listening who maybe aren't optometrists or in the eye care field, the eyelashes pick up tons of stuff and we got to get that stuff out. So I'm usually starting looking at the eyelids and then moving on from there. That's where I start. Jason, how about you?
Yeah, and if you're just listening and you're not actually watching this dialogue, Nick has amazing hair, and so he knows everything about
He
taking
knows
care.
all about washing hair.
He knows he's got the routine down. So if you're not able to watch this,
He's got the flow.
you'll have to look that up later. I think you're right. These patients coming in for surgery. I'm hoping one that the referring doctor again is looking to diagnosis and start the patients ahead of time so that when they come in, most of this is being managed. But sometimes patients are sent in on their own or come in on their own. And I think it's just getting back to the root cause. If I divide it in half, my aqueous deficient patients, I'm doing plugs and restasis probably is my first step. If my meibomian gland dysfunction patients, I'm doing probably a heat treatment like LipiFlow or TearCare first, warming mask and fish oil. So that's kind of how I kind of break it down the middle. If it's more than that, instead of doing surgery, we'd probably take a time out, have them come back, repeat some things to make sure that we're getting them back on track and go from there. If it's just a strict dry eye patient coming in, again, it's kind of the same thing. It's just getting to the root cause. But yeah, I agree that, getting the eyelids real clean, blepharitis, there's actually so again, if you're not watching this, I don't even know if we're having this on
I
video,
don't know
but
if people want to tune in to this,
well,
right?
these nasty lashes are what we see in the microscope. And so, all these little things on the lashes are actually in blown up mode, this giant bug that's in your eyelash, this mite. And so we want to get these things out of there because they get into the tear film, they irritate our eyes, and so you can't have those. So there's some really good drops out there that work on that. And I've been amazed at how well they work. I don't know if you guys have used some
Yeah,
of these things, but
I have.
in several weeks they're gone. And so it's good. Some of the serious patients, we make eye drops out of their blood. There's a way to make eye drops out of your blood. So we draw some blood, spin the red blood cells away, you get the clear plasma, we dilute that down, and that has the same biochemistry as your natural tear. So anytime we can try to get something very close or similar to your natural tear, that's amazing. And so these drops have increased growth factors. There's platelet derived growth factors, and they're all compounded, and we just make them in the office, or we can send you to a place that can do that. But those things work really well. And then one more thing on just natural tears is there's a sensory nerve in your nose, and if we can stimulate that with a nasal spray, and maybe people have seen that around, but that works really well too. That you then stimulate your own natural tear production even more so.
One more thing I wanted to say is when you're first, addressing this patient with dry eye, what are you doing? Asking them what they're doing. if they're using an artificial tear once or twice a day and they're doing well with that, that's actually me. So I wake up, I put an artificial tear in, preservative-free tear gets me going, and then I'll usually put one in before I go to bed. I don't consider myself to have chronic dry eyes. Um, I think artificial tears are really good at treating like situational dry eye. It tends to be cold in the Midwest, so you're driving, you got heat blasting in your face. And you get out of your car and your eyes are dry. Artificial tears work great there. I think if we expect, artificial tears to, treat chronic dry eye, or if a patient's using an artificial tear 6 or 7 times a day, there's something better that we can be doing, or there's something more that we can be prescribing for them. So artificial tears are awesome. We use them a bunch. They help really well with after surgeries. But when a patient starts using an artificial tear more than 3 or 4 times a day, we got to be doing more for our patients.
So I look at surgery, we need to get the tear film as pristine as possible before we do any eye surgery. And so diagnosing dry eye before surgery, I like to say that's the patient's problem. If we don't diagnose that before surgery and you start diagnosing it after surgery, well, now that becomes the doctor problem. And I think we just have to remember that we want to get good surgery outcomes. So we need to be better at diagnosing it before surgery so that we can get patients on a plan and they become part of that solution. Now, non-surgery, in eye practices and in optical practices that are doing glasses and contact lenses all the time. I mean, remakes happen and you can have patients being frustrated that they're not seeing clearly. And those same rules apply to prescribing glasses and contacts too. So try to be more on top of diagnosing this stuff at the time of you're prescribing glasses. And it may mean taking a time out as well, having them come back, make sure that the tear film looks better, and then prescribe glasses or contacts at a later date. So those are just kind of good rules of thumb.
Yeah, or like contact lens dropout. Patients are in our chair wanting LASIK, which we love that. And LASIK is always a great option. But one of the I always ask this question, okay, so you wear glasses and do you wear contacts? And they go, oh yeah, I wear contacts, but lately I've been wearing glasses because my contact lenses are bothering me. And they're just, by the middle of the day, I want them out. Well, I probably am going to want to work on dry eye treatment before LASIK, because number one reason of contact lens, discontinuing them is dry eye. And so assuming that my tests correlate with all of that, it would be my job to work on dry eye, maybe repeat scans, do whatever I need to do to make sure that they're prepped and ready for surgery.
It's a pretty good point. I was actually just writing up a case this morning of a gal that was referred to me last year for dry eye consult. She would wear her contacts like 14 hours a day. But it was so odd because she would say, my eyes feel better with my contacts in. And I wish I could take them out more, because I know I should, but when I take them out, my eyes hurt worse. And so for her, like, her eyes were so dry, her contacts were just acting like bandaged contact lenses. Her contacts were acting like a Band-Aid. But that was the reason her eyes were so dry. So I started some therapy. I said, I'd really like you to, reduce your contact lens wear. I was supposed to see her back in a couple of weeks. I never saw her again until 6 months later. She showed up even worse. And we finally got her committed to the therapy. We did Sidra, we did plugs, we did Bruder mask, we did Avenova spray, short course of a loteprednol steroid to get her going. And before she left, she said, can I have LASIK? And I said, maybe someday, but like not right now. And 9 months actually from the first time I met her, we started therapy. She discontinued her contacts for 6 months. And then we just did LASIK like a couple months ago. So from the time I met her, 9 months later of therapy, she was able to have LASIK. But you've got to treat these beforehand, because if you do LASIK on a dry eye, you're asking for just, nightmare. It's so
outcomes
tough.
are going to be
It is so tough.
The patient experience is going to be unpredictable, and so we just don't want any of that.
Yeah.
Lorraine, you mentioned proper nutrition, limiting, tobacco and alcohol in your diet. And, actually caffeine has actually been shown to be beneficial for dry eye patients. So that's good. But just sleeping better, having a good mental health state of mind and being, all those things are important.
Sleeping with a fan on. When we go to sleep at night, just to piggyback onto what you were just saying, we close our eyes at night and go to sleep, and sometimes their muscles are so relaxed, they open just a tiny, tiny bit. And you have the circulation of the fan going on in the room. And that circulation can cause dry eye. So sometimes or worse, of course, in the morning, they wake up and they feel like they have to peel their eyelids open. When we take a look at patients like that in the slit lamp, a lot of times all their dryness is on the inferior half. And then you start asking, okay, does their lid close all the way? Are you sleeping with a fan? Do you have a CPAP on? Some like environmental changes that they could make in their house or daily lives that would also treat this. Yeah.
I think that's a lot more common than we think. Patients get really surprised when I ask them if they sleep with a fan or sleep with a CPAP, and they're like, holy, how'd you know? And I can say, well, actually, I have that problem. My left eye is always a little dry when I wake up in the morning because I sleep on my left side every night, usually because my 3-year-old is next to me putting her feet into my back. So I have to roll away. And then my left eye is on my pillow and my left eye doesn't completely shut. And so I have that problem. I know my patients also have that problem. But lifestyle changes with the fans are huge.
Yeah.
Yeah. A couple things too. I mean, you see a lot of, the gold standard that patients think is to use an eye drop called Visine, right? That helps to get the red out. If the eyes are dry, they're going to get inflamed and be red. And so this drop is really helping me because I'm getting the red out. And there's some other ones that are out there that have also helped to get the red out. But actually these things over time can actually make your eyes more red and more irritated. So again, like Nick said, if you're using drops more than a few times a day and on a like every day, all the time, something else is going on. We got to get to the bottom of it. And Lorraine, I know you do a lot of glaucoma patients. I mean, even other drops that patients put in their eyes can have an effect on the ocular surface.
Yeah. I say, like, don't get me started on patients with glaucoma drops. But it's starting to not be the first line of treatment for glaucoma. I would say the old standard of care was start treating patients by IOP or pressure lowering drops. And these pressure lowering drops, they serve a purpose, and the purpose of those drops is to lower the pressure and treat the glaucoma. The purpose is not to treat dry eye. And so just like Nick stated before, these drops have preservatives in them that are toxic to the surface of the eye. And drops certainly have their part in glaucoma, but the better it's better for the patient if we can avoid drops. So if we can do a laser procedure or something else that we can make sure a patient is off drops, the better off their eyes are going to feel. And so, I see a lot of patients treat a lot of glaucoma, and a lot of them have red, irritated eyes. And sometimes that's the only option in some cases, but most of the time we're able to do a procedure or even get them on a preservative-free glaucoma drop is also very helpful, But, there's other diseases, not even just cataracts or cataracts and glaucoma, but there's certain things that can develop on patients' corneas or the surface of their eye from dry eye. Like we see a lot of what's EBMD or epithelial basement membrane dystrophy in patients. And that's just where the surface of your eye, the cornea, the epithelial cells are just kind of, it's like they're not quite as uniform as they should be. And they're kind of, mumbled and jumbled into an area, and that can cause blurred vision. And I always tell patients the reason why you have that is probably because of chronic dry eye. And so not only are we going to maybe do a procedure to fix those surface cells to be nice and smooth, but we're going to treat the underlying issue, which is dryness. So it might be plugs that we put in, or starting a cyclosporine or something like that, to try to target the underlying issue so that that doesn't come back even after our surgery. And all of these things, you know, that I just mentioned, whether it's doing a procedure for the EBMD or the glaucoma or cataracts, you know, I would say that surgery in general, to be free of glasses, is becoming very, very popular, right? Cataract surgery in a sense is a refractive surgery. And what that means is that more people are wanting to be free of glasses and free of reading glasses, or, you know, whatever it may be. They don't want to be in contacts. They don't want to be in reading glasses because of their lifestyle or whatever it may be. Just like the gentleman raising his hand. But, you know, when it becomes a refractive procedure, you know, that's when dry eye and treating that and making sure that their, you know, eye is pristine and ready for surgery, that's when it becomes such a valuable part to that, is because, you know, people pay good money to be free of glasses and stuff, and we better have them prepped and ready so that they have a good outcome.
Your tear film interface is an important part of how you see. It has a refractive part of how you see. So if you don't have a good tear film, no matter what we do, the quality of vision isn't going to be there. So it's the tears, the cornea, the lens, the vitreous, the retina. Everything has to be taken into account when we figure out what's the best way we can get patients to see, whether it is glasses or contacts or surgery.
I think a lot of patients can get confused. Because, like, you know, I'll have somebody wanting LASIK, or having somebody wanting a multifocal lens for cataract surgery. And I've said before, I don't think you're ready for it yet. We need to treat this dry eye. And they say, I don't have dry eye. My eyes don't feel dry. And so I've started rewording I say, you're right. Your eyes don't look terribly dry. Your eyes may not feel dry, but this is a tear film instability issue. I can see your tears breaking up on the surface. Your tears are not stable. That is the first structure to refract light. So, you know, dry eye patients might not grasp onto, because if they don't grasp onto the diagnosis and they don't believe you, they're not going to do the required treatment or do the recommended treatment. So even in the room, I've started saying, you know, your tear film is unstable, and we need to treat that in order to get you ready for surgery. Because I've said dry eye before, and I actually get pushed back in the room because they're demanding that their eyes aren't dry. So I switching the verbiage up and saying, like, tear film instability, we got to work on these glands on your eyelid first, getting you ready for the surgery to give us a better outcome. I found helpful, because patients won't abide to a therapy if they're not bought in, believing that it's going to be beneficial.
Yeah, I think that's an important point, Nick. I think, you know, some of these point of service tests that we have, whether it's, you know, checking osmolarity or inflammation, or if we're imaging the glands, or even a Schirmer's test, or the fact that we're using just stain on their cornea, just having a reason of why how did we come up with that diagnosis, you know? And like we said, stage 1 is asymptomatic. A lot of diseases are asymptomatic. Blood pressure is asymptomatic. Glaucoma is asymptomatic. 27 cavities is asymptomatic, you know.
23.
27. Just add it. We're just going to keep adding to it.
Keep going up and up.
So I think that's important, having that discussion with the patient, you know, instead of having a discussion at the patient, getting the patient involved and having them understand what you know. That's important. A couple things, you know, there are some new products in the pipeline coming out. They kind of all do the same thing. They help decrease inflammation and increase tear production. RASP inhibitors, steroids that we put into the tear duct. There's topical minocycline ointment that helps improve inflammation. So there's some other things that we'll have in our toolbox to use as we go down the road. But so as we kind of go into the next segment, this is just kind of to further explore various aspects of dry eye disease, kind of like what we've been doing. But I don't know, you know, kind of to wrap it up, I thank you both for joining today. There's a lot of valuable insights here. This was a wrap up of today's dry eye dialogue. Until next time, I guess, stay curious and keep learning. The world of eye care is ever changing, and so are we. I want to thank Lorraine and Nick for engaging with us today. Make sure you visit our website and follow us on social media for additional resources and updates. Tune in next time for an awesome discussion on the Sharp Science Sessions, all things LASIK. Well, I'm your host, Jason. Take care and good night.
Thanks, Jason.